on the Stanford Global Health website. Please keep sending us your questions in the chat box as well. Closed captioning will be on. Feel free to turn it off if you don't want it. I know we were not able to answer all your questions during the last webinar in the live session, but in the past several days, we worked hard on answering several hundreds of your questions and have posted the answers to your questions on the Stanford Global Health website as well. We also posted a new video on vaccines because there were multiple questions on this topic. We have posted several other material on the Global Health website as well. I am Dr. Nidhi Rohatgi, a general medicine doctor at Stanford Hospital and a director of clinical research in the Division of Hospital Medicine. I served as an investigator for several clinical trials in COVID-19, including Remdesivir, baricitinib, tocilizumab, and other immunomodulators, and blood thinners in COVID-19. It is my privilege to organize these webinars in COVID. Today, we will focus on blood thinners in COVID-19, COVID-19 in children, pregnant, and breastfeeding women, and how COVID can affect our heart, lungs, and other parts of the body in the long term. I am very excited to introduce our fantastic panel of expert doctors today. Dr. Caroline Berube, she is a hematologist, a blood disease doctor, and really there is not a single protocol or a major decision on blood thinners at Stanford that does not include her input. Dr. Rasheen Reed-Singhani, she's a cardiologist at Stanford, a fantastic clinician, and has a lot of experience on how COVID can affect our hearts. Dr. Angela Rogers is an ICU doctor and a lung specialist for adults, and the chair of the ICU COVID task force at Stanford that helped create several protocols on how to care for our patients at Stanford in the ICU with COVID-19. Dr. Aruna Subramanian is a clinical professor in infectious disease at Stanford, and both Dr. Rogers and Dr. Subramanian took care of our sickest adult patients with COVID, and both have been investigators on several clinical trials in COVID. Dr. Roshni Matthew is an infectious disease specialist for children at Stanford. Dr. Matthew also created several protocols for prevention of transmission of COVID in our children's hospital. Dr. Alan Schroeder is an ICU, critical care, and hospital medicine doctor for children at Stanford. Both Dr. Schroeder and Dr. Matthew have a lot of experience treating acute COVID-19 in children and a very rare but serious medical condition in children with COVID called MISC, or Multisystem Inflammatory Syndrome in children. Dr. Natalie Aziz is an OBGYN doctor and reproductive and perinatal infectious disease specialist at Stanford. She led our teams for clinical management for COVID-19 in pregnancy, not only at Stanford, but is also actively involved in policy development and research in COVID-19 and pregnancy across the United States. So let's start with blood thinners in COVID-19. Dr. Berube, I'm going to go with you for the first question. How common are significant, spontaneous bleeding and clotting events in COVID-19?
Thank you, Dr. Rohatgi. First, let me start by saying that our hearts go out to you who are in India or who have family in India in this difficult time. To get back to your question, there is no doubt that clotting and bleeding events can be a serious complication of COVID-19. Early on in the pandemic, there were several reports of very high rate of blood clots, despite the use of standard prevention protocols in the hospital. But as we got better at managing COVID-19, many institutions have since reported much lower rate of clotting complications. So what type of blood clots do we see? Clots in the legs or the lung, also called deep vein thrombosis or pulmonary embolism, are most common in COVID-19, but we have also seen clots in the artery causing stroke, heart attack, or acute blockage of the circulation in one limb. These are medical emergencies requiring evaluation and hospitalization. Now, how frequent are those blood clots? Well, not everyone is at the same risk, and the risk increases as someone gets sicker from COVID-19. The risk is the highest for inpatients. So for non-ICU patients, the rate of blood clot is less than 5%. But patients requiring ICU care have a rate of about 10%. Again, this is much, much lower than initially reported in the beginning of the pandemic. Bleeding complications have also been reported, but they are less common than the clotting issues. In contrast, for those of you who have mild symptoms who don't require hospitalization, the risk of clotting is much lower. Therefore, we don't routinely administer blood thinners to people staying at home for prevention of clotting, except in very selected cases.
Thank you, Dr. Berube. Dr. Berube, we got a lot of questions about D-dimer. Is there a role of D-dimer in deciding who should or shouldn't get a blood thinner if they have COVID? And if you do get started on a blood thinner, can you use D-dimer to decide when to stop that blood thinner?
Yeah, thank you for this question. D-dimer is a marker of activation of the clotting system. It is a blood test that is often obtained in patients who get admitted to the hospital with COVID-19. It is often elevated, raising concerns about the risk of clotting. But we learned that the D-dimer level correlates with the severity of the viral illness, but it's not non-specific, and we don't make anticoagulation decisions based on these D-dimer results. In the outpatient setting, whether it's prior to admission or after hospital discharge, we don't monitor D-dimer or coagulation tests. In terms of duration of anticoagulation, it depends on whether there has been a new diagnosis of blood clots or not. If the answer is yes, we would give blood thinners for at least 3 months, similarly to other patients diagnosed with blood clots. In the absence of blood clot, we would stop anticoagulation at discharge in most patients. We do not use levels to decide when to discontinue anticoagulation. Dr. Rogers, would you like to add anything on this?
Yeah, I agree with you, Dr. Berube, very much. Dr. Berube was the expert that we turned to in our ICU when we had questions about, there's a lot of clotting. Should we be using blood thinners routinely? And in the early days, we weren't sure. There are several publications that are in preprint, and I believe will be coming out under peer review in the next month. I'll put the preprint into the chat so that physicians on the call can read them themselves, that really looked at this question of, should we be, given the higher risks that Dr. Berube described, should we be using blood thinners in our hospitalized patients, either on the floors needing oxygen or in ICU? And I know that some of you are caring for loved ones on oxygen at home who might be as sick as some of our patients that are in the hospital on oxygen. And the data does show in patients that need oxygen but aren't sick enough to be in ICU that there is a small benefit for those patients in terms of keeping them alive. But as Dr. Berube said, there is a higher bleeding risk, and experiencing a bleed at home is much, much more risky than experiencing a bleed in the hospitalized setting. And so we would not routinely recommend being on full blood thinners at home based on the degree of evidence that we have. That is not something that I would do for a loved one outside the hospital setting. And just as she mentioned, the D-dimer is a risk. It shows us that you're sicker than a person without as high a D-dimer. But even in those papers called Active 4, which I will put in the chat, it did not suggest that higher D-dimer got more benefit than lower D-dimer. So I wouldn't use that to help guide therapy.
Thank you both. Dr. Berube, I'm going to go back to you. In which group of patients with COVID-19 did we give blood thinners at Stanford? And is there really a harm in taking blood thinners if we are so worried about blood clots with COVID?
Yeah, that's a good question and a difficult one. So first, I want to say if you are already taking aspirin, Plavix, or a blood thinner for a different health condition, you should continue taking this medication just as before. If you don't need to be hospitalized for COVID-19, your risk of blood clot is low, so we do not usually prescribe blood thinners to these individuals. So who gets prescribed blood thinners at Stanford currently? So those with COVID-19 who are ill enough to be admitted to the hospital should receive some type of anticoagulation unless there is a contraindication. We have been using low-dose enoxaparin or heparin for prevention. In the ICU, we have been using slightly higher dose of anticoagulants, although standard low dose might work just as well. However, we have not recommended full dose anticoagulation as a standard of care unless there was an established indication for this. For months since the beginning of the pandemic, there has been a lot of controversy over what the optimal dose of anticoagulation should be. This is a very complex issue, and recent studies attempt to answer this difficult question. And for ICU patients, preliminary results showed no benefit of full dose anticoagulation compared to lower dose, and was actually associated with more bleeding, thus harm. Thus, full dose anticoagulation should not be used in ICU solely for the prevention of blood clots. In contrast, just like Dr. Rogers said, for hospitalized patients not in the ICU, recent data suggests that full dose anticoagulation might bring a little benefit. It is important to note that these are preliminary results posted online, and we are waiting for the full publication before we make changes to our internal protocols. But in my view, full dose blood thinner for acute COVID-19 should only be administered under close monitoring in the hospital. This is not for home treatment.
Thank you, Dr. Berube. Dr. Berube, you mentioned enoxaparin, and that is what we commonly use in our hospital here. What do you think about apixaban or rivaroxaban if enoxaparin is too expensive or not available, or someone is really afraid of needles?
In the hospital, our go-to blood thinner is really the injectable enoxaparin or heparin. Apixaban or rivaroxaban, two oral blood thinners, are not our first choice due to drug interaction with the antiviral drugs, the concern for impaired absorption if you have during COVID illness, or for the concern for gastrointestinal bleeding. For those of you who are at home, we understand it is very tempting to take anything that could potentially help. However, there is currently no data supporting the routine use of apixaban or rivaroxaban in the prevention of clotting after being diagnosed with COVID-19, and we must always consider the risk of bleeding. There are ongoing studies looking at the potential benefit and safety of these oral blood thinners, but we don't have answers at this time. So overall, the use of preventative blood thinners should be reserved for patients who are hospitalized with COVID-19 at this time and patients who can be monitored by a medical team.
Thank you, Dr. Berube. That's excellent. Dr. Reed Singhani, I'm going to go with you for the next question. What are your thoughts about giving a baby aspirin, either 75 milligrams or 81 milligrams, to all people with COVID for preventing heart attacks in COVID-19?
Dr. Rohatgi, thank you so much, and thank you to the organizers for having us here today. And to the audience in India, good morning. As someone who's done my MBBS from Mumbai, I will say that, to the backbone of people who have fought this response to COVID in India, the doctors, nurses, healthcare workers, students, family members, we really commend you, your dedication, your courage. And you have really been an inspiration to all of us across the world, and we really are rooting for you. In response to the question, so there has been some data that has actually looked at the use of low-dose aspirin for different things in COVID, and there are some smaller studies that have actually said that perhaps there are improved outcomes, such as less mortality in the hospital, less ICU stay, but these are very small studies, so we have to take them in context. There are hopefully larger studies coming that may shed some light on this, but none of these studies have particularly looked at the cardiovascular events with low-dose aspirin. So based on that, I think from a cardiac perspective, for prevention of heart attacks, for prevention of cardiac disease, what I would say is we would still go with our original recommendations, which is if you have known coronary disease, if you have other heart conditions for which you need low dose aspirin, then that should be continued. There's no need to stop it. But if there's no indication to be on aspirin, either as prevention or as treatment, then we wouldn't recommend widespread use. And the reason for this is because even though it seems like a very low dose of aspirin and it seems safe, we have seen increased bleeding, certainly in conditions including COVID, where there can be derangement of the coagulation pathways. So we have to be a little bit careful and make sure we're selecting our patients correctly before giving this medication.
Thank you, Dr. Risingani. Dr. Schroeder, we talked about adult patients with COVID-19 so far. Do you use D-dimer in children with COVID, and do children get blood thinners if they have COVID?
Yes, thank you, and good morning, everybody. So a couple of things about kids. There's sort of two bits of good news on the clotting and COVID front. One, kids don't get as sick with COVID, and two, kids in general tend not to get blood clots. So really kind of easier for us. We rarely use anticoagulation except for in the sickest kids. So if a child is in the ICU with critical COVID, we will certainly consider it. If they have risk factors, we will almost certainly do it. So the sickest children that we've had with acute COVID, we'll talk about MISC, I think a little bit later, which is not really acute COVID, but a delayed COVID presentation. But the sickest kids have tended to be older adolescents, oftentimes obese, and we have used anticoagulants in them, mostly prophylactic enoxaparin, but we've not used D-dimers to help us make those decisions.
Thank you, Dr. Schroeder. Dr. Aziz, what is the data on preventing blood clots in pregnant women with COVID-19 or those who are breastfeeding? Are D-dimers helpful in pregnant women for this purpose? Dr. Aziz, you're on mute.
Thank you for reminding me. Thank you, Dr. Rohatgi, and good morning to the audience. Thank you all for participating and joining us this morning. That's a very excellent question, and like many pregnancy questions, unfortunately, we have limited data. However, there are some studies that show that pregnant women with COVID are at an increased risk of clotting over that of pregnant women without COVID. And as we know, pregnancy itself increases the risk of blood clots to a certain degree. So what we typically do is, and the general anecdotal recommendation has been that if patients have severe or critical illness and are hospitalized, we do proceed with prophylactic anticoagulation. Again, enoxaparin if delivery is remote, and otherwise unfractionated heparin if there is a risk of delivering the mother. Additionally, given that pregnancy actually physiologically increases the D-dimer levels with each trimester, we do not use D-dimers in pregnancy itself, let alone with COVID and pregnant women. So D-dimers we do not use. We do anticoagulate those women who are in the hospital with severe or critical illness. And again, with postpartum patients and those who are going home after recovering from severe illness or critical illness, we do have a case-by-case type of management protocol that we do at our hospital, but there's no standard recommendations for outpatient management. However, I think that we do need to think about case-by-case and individual cases in terms of prophylaxis for outpatient under the management of physicians, of course, and just for weeks between 2 to 6 weeks, depending on their critical nature of the illness.
Thank you, Dr. Aziz. Dr. Aziz, is aspirin ever given to pregnant women?
Absolutely. Aspirin is commonly given for prevention of preeclampsia, and therefore we readily use it for women who have chronic hypertension or diabetes or history of prior preeclampsia or hypertension. However, we do not routinely, again, administer aspirin for women with COVID. However, if a patient is on aspirin and has COVID, we continue her therapy without issues.
Thank you, Dr. Aziz. We are now going to switch to COVID-19 in children. So, Dr. Matthew, there is a big fear that there will be a third wave of COVID in India. and children may get affected. What are your thoughts about this third wave?
There is not a particular reason why children would be disproportionately impacted, even if there were a third wave. What we've known throughout the pandemic is that the clinical manifestations in children have been pretty consistent. The incidence in children has been pretty proportional to community prevalence. So the moment you see an increase in community prevalence, we see larger number of infected children. And so I would imagine that as the number of individuals get immunized and there is larger community immunity, the number of people who are infected, the adults who are infected, would go down, and hopefully that will also impact the number of children. So I do not think there is a particular reason to be concerned that children will be impacted differently if there were to be another wave.
Thanks, Dr. Matthew. Dr. Schroeder, anything to add to that?
No, I think that was perfectly said.
Thank you. Dr. Matthew, I'm going to go to you again. What suggestions would you have to protect children from COVID? The really young ones cannot wear a mask. What are your thoughts about school reopening? These have been the questions that have been coming up all along, even for us here.
So the protection against COVID, the strategies have not changed. So thankfully, we know that those strategies do work. So for young children, particularly right now in India, where there is a lot of community activity, I would recommend that you stay indoors as much as possible within your own household, avoiding crowded spaces, avoiding areas, closed spaces without good ventilation, where you cannot really physically distance from individuals from other households. So usual strategies that we've been doing since the start of the pandemic would still work. The very young children who are less than 2 years of age, we would not recommend that they wear a mask because it's mostly counterproductive. They will be adjusting their mask and they'll probably be contaminating their face more so than protecting themselves. And there is always a risk of suffocation or something else with the very young children. So even if they cannot wear a mask, there are other strategies that should still be protective. So that's pretty much it about protecting infection. In terms of school reopening, just within the United States, as well as information from several other countries that have gone through waves of pandemic, we know that schools have not been a primary area for transmission. So children have been infected, but mostly from the community, and thus going back to children's infection is pretty much a consequence of the community activity more than children being the primary individuals who actually cause transmission. So even if children went to schools with infection, the risk of infection to other individuals was very low, even in areas of high community prevalence when schools were reopened. So as long as, and of course, the caveat is that these schools did use precautions within school environments. So they either, they used the masking and physical distancing, reduced the number of people that came in at a given time. So all of those measures were in place. And so we do know that those strategies work. At this moment in time, where the community prevalence is so high in India, it is obviously not a good idea to open up areas, including school, because that would just increase the amount of activity and commingling and transmission. But once there is sustained control over the infection, school reopening could potentially happen safely.
Thank you,
And
Dr.
just to
Matthew.
add that the corollary is that there are health risks of keeping schools closed too, particularly around mental health, which we're seeing quite a bit of. So those are like everything in this pandemic, we've had to really balance those things. And as hopefully prevalence starts to decrease in India, keeping in mind the negative ramifications of keeping schools closed is an important consideration.
Thank you, Dr. Schroeder. Dr. Schroeder, could you also tell us what are the common symptoms of COVID-19 in children?
Yeah, sure. For reasons that are still being explored, kids just aren't getting as sick. A number of hypotheses on that, including the fact that they seem to have fewer of the ACE2 receptors in their respiratory tract. When they do get sick, they tend to have symptoms that are similar to adults. So, and they're fairly non-specific symptoms. They don't get as sick, but when they do, it's similar, and that's mostly respiratory stuff, but it can be GI manifestations as well, fatigue and other systemic symptoms. But many are asymptomatic. And in fact, we just looked at our own hospitalizations where we do universal testing at Stanford, and about 45%, almost half of our kids who were tested positive were totally asymptomatic for COVID. So that's been one of it's been nice that kids aren't getting as sick, but it's also created some challenges for transmission as well, given how many are asymptomatic.
Thank you, Dr. Schroeder. Dr. Matthew, are there any approved treatment for COVID-19 in children?
So unfortunately, we do not have any trials in children that have shown any drug to be particularly helpful. As Dr. Schroeder was saying, we have actually seen many children who are infected, but a lot of them have been asymptomatic or have had mild to moderate illness, so they did not require supplemental oxygen, for example. Those children would not require any kind of targeted therapy, just supportive care. Children who have been classified as severe to critically ill, so these are children who required supplemental oxygen or who have other manifestations like multi-organ system involvement, significant inflammation, pneumonia. So in those instances, just like in adults, we have extrapolating mostly from adult data, not having anything on children themselves. We do use Remdesivir or plus minus steroids, depending on where the trajectory of illness they are. And whenever we use, for example, dexamethasone, we use it for 10 days, or Remdesivir for 5 days, and sometimes up to 10 days, depending on the situation. So overall, those have been the strategies. We don't use a lot of convalescent plasma, tocilizumab, all of those are very infrequently used in children.
Thank you, Dr. Matthew. Dr. Matthew and Dr. Schroeder, you worked a lot and published on MISC. Could you tell us a little bit about MISC? Who can get it? How does it present? Is there a genetic marker or a blood test? And can we really prevent it?
I can start and Dr. Schroeder can add. Multisystem inflammatory syndrome in children, that is the CDC's acronym MISC, and then there is the UK acronym, which is PIMS -TS, or post-inflammatory multisystem syndrome in children temporally associated with COVID. So basically, this is a post-infectious phenomenon. We usually see this about 4 to 6 weeks after the original infection with SARS-CoV-2. And the original infection with SARS-CoV-2 may be asymptomatic, or they never even knew the child ever was infected. Sometimes there is a history of household contacts that were positive, for example, but the child themselves may not have been sick with COVID. But about 4 to 6 weeks later, they develop this very exaggerated immune response, characterized primarily by fevers that last for several days. A lot of these children do have gastrointestinal symptoms, so severe abdominal pain, nausea, vomiting, diarrhea. Some of them can have neurological issues, and some of them can come with rash, conjunctivitis, or pink eye. So these are the typical manifestations. So some of these children can come with low blood pressures. And so obviously Dr. Schroeder in the ICU would be seeing patients who are in the extreme end of the spectrum. We have seen MISC children who are much milder, who never required ICU or required any specific treatments. And the thing with MISC is there is no genetic marker per se or specific test. It is a syndrome, so that it's based on clinical presentation and laboratory, suggestive laboratory data. And there is no way to predict which child will end up with MISC either. So that is a little bit of an issue. I forgot to mention that MISC typically also can have cardiac manifestations. So that's a little bit about MISC, and I'm sure I missed some important points that Dr. Schroeder can add.
I think you covered almost everything. The only thing that I would add that's just been sort of interesting about the differences between acute COVID infections and MISC is that the kids that tend to be getting sick with acute COVID infections tend to be kids with risk factors, either immunocompromised patients or severely obese patients, diabetics. Whereas MISC, we're seeing happening in healthy kids. The average age is about 8, and most of the kids are healthy. And in both cases, we're seeing really disparities, disproportionate amounts of cases in certain racial and ethnic minorities, and that's been really an unfortunate part of all of this. But it has been interesting to distinguish how complex kids are getting sick with COVID, but healthy kids are getting the MISC, which is one of the reasons why so many people are pushing for vaccination of children, because their kids are getting sick.
Thank you, Dr. Schroeder, Dr. Matthew. Dr. Schroeder, how common is this MISC? Is this, it sounds a very serious condition, but is it common?
It's very, very rare, actually. And because there's a lack of a definitive diagnostic test, and it's more of a constellation of symptoms. We have CDC criteria, but they are, even the CDC will admit, they're imperfect. So it's hard to know the exact numbers. We think that probably there's been between maybe 30 to 50 deaths from MISC in the United States. In California, the state of California, which is the largest state, we think there's been somewhere around 300 cases or so. So when you put that in the context of obviously adult numbers for COVID or the overall population numbers, it's very, very rare. But in general, kids are pretty healthy. And so even rare but serious things we worry about and try to prevent.
Thank you, Dr. Schroeder. And Dr. Schroeder, very quickly, could you tell us a little bit about inflammatory markers? In adults, in the last webinar, we talked about how blood tests and inflammatory markers are really needed only in the severely sick adults. What is your experience with inflammatory markers in children?
Yeah, I see very little role for them in acute COVID infections. There are a lot of labs, probably too many labs that we get for MISC, and that's because people are still trying to figure out the condition. So lots of inflammatory markers, cardiac enzymes, those sorts of things are obtained in MISC, but in general, I see very little role for acute COVID infections.
Thank you. We're now going to move on to COVID-19 in pregnant and breastfeeding women. So Dr. Aziz, in your experience, both at Stanford and through our national database, how did pregnant women with COVID-19 and their babies do, both during the acute illness with COVID and then months after?
It's an excellent question and something that's very important to reproductive aged women and families. Thank you for asking that. So fortunately, I'd like to reassure our audience that most of the infection in pregnant women will be asymptomatic, so up to about 90%. And we have seen that both at our hospital as well. So we're a tertiary care center, and we screen all our pregnant patients who come in for labor. And we've actually discovered that only about 15% are symptomatic and over 85% are asymptomatic. And that is consistent with general findings that have been published as well. And most women, again, 90% or more, will not require a delivery management or hospitalization for their COVID. However, there is a small percentage, approximately 10%, who may have severe or critical illness, and shorter than that or smaller than that, then those may be hospitalized in the ICU. And what we have found, similar to other respiratory disorders like H1N1, in which pneumonia is a contributing factor to hospitalization in pregnant women, that pregnant women with COVID compared to non-pregnant women with COVID tend to have higher adverse events, including hospitalization. And that might be a little bit of selection bias because we're more likely to hospitalize pregnant women. We're more concerned. However, hospitalization, ICU admission, ventilation have been noted to be higher in pregnant women who have COVID compared to their same age-based comparisons who are not pregnant with COVID. From a perinatal aspect, we have noticed, fortunately, Again, in the first and early second trimesters, it does not seem to be associated with congenital defects or miscarriages. So those are very reassuring, or infertility, for example, for those of us that are planning families. So those are all reassuring things. We do tend to see that women who are in their later second trimesters and in the third trimester, and those especially with pneumonia and severe respiratory illness, again, may tend to be more likely to be admitted to the ICU and may require preterm delivery, indicated only for maternal health, basically, generally not for fetal indications or fetal reasons, but more to help the mother's status for respiratory improvement. And we've seen that in our hospital and in a few other California hospitals in which we're in coalition with, in that those women that are after 30 weeks, 32 to 34 weeks being somewhat of a line, that may improve after delivery, in that the gravid uterus is no longer compromising their respiratory status, and we see a very promising improvement. So that then brings to light preterm birth and potentially cesarean delivery, because as some women are very respiratorily compromised, they may not be able to have the ability to push during a vaginal delivery. And finally, just wanted to say that it's very important to again remember that over 90% of women may have either asymptomatic disease, and of those symptomatic, which is about 15% or so, most will be mild or moderate, and very few are severe or critical. But I think it's very important that if a patient begins to develop symptoms, the key importance is to get her to a hospital. Pregnant women can decompensate faster, especially in the third and late second trimesters. So getting them to the hospital for management is most important. And I know many people worry, and that's why we think that the stillbirth rate went up a little bit during the COVID pandemic, in that pregnant women weren't coming to the hospital when they weren't feeling their baby move, or pregnant women weren't coming to the hospital when they were having higher blood pressures and having preeclampsia, for example, or other issues. But we think that that probably was due to the fear of going to a hospital and contracting COVID amongst other patients. And I really want to encourage and reassure patients that we should go to the hospital when pregnant and when having those symptoms, because early treatment is really important and is very helpful for pregnancy and perinatal outcomes.
Thank you, Dr. Aziz. Dr. Aziz, is there a role for Remdesivir in pregnancy with COVID?
Absolutely. We use Remdesivir similarly as to non-pregnant adults, and Dr. Subramanian and our team actually collaborated on many patients and treated our pregnant patients with Remdesivir while they were hospitalized for their illness. And there is a lovely large case series of almost 90 patients who were pregnant. And one of our colleagues, Dr. Blackburn, is part of that group that also was published, again, demonstrating the benefit and the safety of Remdesivir in pregnancy. So I would definitely say a very loud yes to that for pregnant women.
Thank you, Dr. Aziz. Dr. Subramanian, would you like to add to this?
I'd like to add that, yes, we had good experiences with Remdesivir in pregnancy. The only thing is, I know that Remdesivir is in shortage in India, and it's hard for people to get it. So, you know, as we've said before, Remdesivir is not really a life-saving treatment. It doesn't have a mortality outcome. So only if you know, you're able to get it, and then we would recommend it. But I wouldn't go out of your way or pay exorbitant fees to obtain Remdesivir, and it's actually not even included in the WHO guidelines anymore. So I think you know, it's something that's a nice addition if you can get it, but not absolutely necessary.
Thank you both. Dr. Aziz, is it okay to give steroids during pregnancy? And if so, which of the steroids are considered safe?
So fortunately, in pregnancy, we also use dexamethasone and betamethasone for promotion of fetal lung maturity when we expect or anticipate a possible preterm delivery. And therefore, the dexamethasone that's used in the management of COVID can be definitely readily applied to pregnant women. If we do think that she is at risk for preterm delivery, we will dose the dexamethasone similarly for fetal lung maturity for the first 48 hours. So it's 6 milligrams every 12 hours for 2 days. And then we go to the 6 milligrams daily to complete the course of the general 10-day course. And therefore, so dexamethasone is typically used here for the treatment of COVID in pregnant women. And again, both for fetal lung maturity reasons, as well as if it's indicated for COVID.
Thank you, Dr. Aziz. Dr. Aziz, I have a few series of questions which we can go through. If the mother has COVID-19, can the SARS-CoV-2 virus cross the placenta and go to the baby?
So this is a really excellent question, and we don't think that it can, or if it can, it's very, very, very rare. So I think that's an important aspect to remember. There have been case reports that have been published regarding placental infection and infant infection, and Dr. Matthew can probably elaborate on that a bit more. But we definitely, for the amount of pregnant women that we have and the numbers that we have, we would expect to see a lot more infected neonates if it truly had a strong transmission possibility, and we do not think that. So the cases that we have seen published, we still think may not be definitive or may have been some type of contaminant. So if it is possible, it's extremely rare, and the course is very mild for the neonates, and I'll let Dr. Matthew expand upon that a bit.
Just to add also that SARS-CoV-2 does not seem to behave like certain other viruses like Zika, for example, which has the tendency to cause abnormalities in the fetus, so we call congenital infection. This is hypothesized to be due to lower ACE2 in the placenta, or it's not really a conducive environment for SARS-CoV-2, and so it's not common to have congenital infection. However, I would like to expand on something from before, that we babies born to COVID-19, moms have generally done very well. Even if babies have acquired infection, those have been usually postnatal, so either during the process of delivery or immediately after. But those are usually in instances where the mom just had acquired COVID a few days before delivery when she is highly infectious, for example. Even in those instances when the babies did acquire COVID, they have done quite well. Just like children in general, even young babies, newborns have done quite well with COVID infection. I would like to add that initially when COVID started, not knowing exactly what this virus can do, mothers and babies were separated, but quickly we came to know that that's not a good idea, and that we can actually prevent transmission to the newborn by following the usual precautions, wherein the mom would wear a mask, wash hands when the mom is nursing or in close contact with the baby. In other instances, the mom would let the baby be physically distant especially during the acute infection phase. And we do know that after about 10 days of acquisition of infection, you are not contagious anymore. So I just wanted to put that out there as well.
And I'll just follow up one last thing to Dr. Matthew's very excellent point, is that we really do support and recommend continuing breastfeeding and nursing the babies. That's very important, and much more important and is the fact that we continue nursing and breastfeeding, as opposed to discontinue that and take away the benefits of nursing for the hypothetical benefit of preventing infection to the neonate or infant. So both the pediatric infectious disease groups and the obstetric and gynecology groups both support nursing strongly in those women who choose to do so.
Thank you. Dr. Aziz, do all pregnant women with COVID-19 need a cesarean section, or can they have vaginal deliveries?
Yeah, so again, this is an excellent question, and hopefully we can reassure mothers that most pregnant women with COVID infection, especially those who are asymptomatic, have no symptoms, or have a mild case or moderate case, can proceed with a typical vaginal delivery trial of labor. Again, it's only in those patients who are typically in the ICU and very critically ill and intubated in that decision for delivery is made. And that decision for delivery is generally based on cesarean delivery because the women at that point are not able to tolerate a typical vaginal delivery induction, for example. But again, COVID in most pregnant women who are infected should not change the course of their delivery mode. And that should be based on the typical obstetric standard indications.
Thank you. Dr. Subramanian, can pregnant women take COVID vaccine, either Covishield or Covaxin? Will the baby be safe? And if so, which trimester may be the best one to take the COVID vaccine?
These are great questions. We don't have data for Covaxin and Covishield yet. We have lots of data in the mRNA vaccines that, especially healthcare workers in the United States and others have taken the vaccines very safely. We usually make the decision based on what is the risk of the pregnant woman getting COVID-19 and her risk of complications from COVID-19 versus the risk of the vaccine. And when rates are very high, especially when there's a lot of exposure, then often we feel like the vaccines are more beneficial and less risky than getting actual COVID-19. So, but it's really always a risk benefit. And maybe Dr. Aziz can talk about how she makes that decision.
Thank you. So I will preface in that we, as the OBGYN community and societies in the United States, supports women to be vaccinated. We, especially since pregnancy has been designated as a high-risk condition alone. So without hypertension or diabetes, but just pregnancy alone puts you at a higher risk of adverse outcome, not for just transmission or infection, but for adverse outcome. So because of that, I advise my patients to accept the vaccine. And given that the two vaccines currently in India, the Covaxin and Covishield. So Covaxin, I believe, is the inactivated vaccine. And even though we don't have data on pregnant women with this specific vaccine, we have been using inactivated vaccines for decades, like the influenza vaccine and the Tdap vaccine. And we know the safety, and we really have historical data by proxy. So I would very much encourage our audience members, our physicians, our medical community to support pregnant women with receipt and acceptance of vaccination. The inactivated vaccines have been, again, very safe historically in pregnant women. Secondly, the mRNA vaccines are used in the United States mostly, but we have had some Johnson & Johnson, which is the adenovirus vector, and that's a similar one as to the Covishield. So again, we do not think that this would be a harmful vaccine by biologic plausibility. And again, if it's available and if it's the only one available, I certainly, again, would advise and support our pregnant patients to receive the vaccine. With respect to trimester, any trimester is fine and safe. Again, we do not have birth defects that have been reported or miscarriages or other adverse events reported from vaccinations thus far. And we have a pretty large cohort of almost 100,000 women who have received the mRNA vaccines in the United States. So we have a large cohort. And the registries thus far, the VAERS registry by the CDC and the databases aren't showing any difference either for vaccinated versus non-vaccinated women in terms of birth defects. So again, I strongly encourage it and advise it. Any trimester is wonderful. And again, whichever vaccine is available, I would encourage utilizing that vaccine. We have more data with the inactivated vaccines just historically, but again, it's just very important to accept the vaccine because none of them biologically are a live vaccine or have shown, these types have shown to have harmful effects on fetuses or mothers who are pregnant.
Thank you, Dr. Aziz. And Dr. Aziz, do the antibodies pass from the mother to the baby through the placenta? Does that happen?
Yes, and we've definitely had some recent studies that have been published that actually show, so we know that antibodies pass from an infected mother to her baby through the placenta. But we also have evidence that vaccinated women will produce these antibodies and therefore passively immunize their infants like they do in Tdap vaccination, for example, for pertussis. So it's very heartening and reassuring, and we're all very happy about that in terms of the ability of antibodies. So it's the IgG antibody that the mother makes that can pass through the placenta and it can enter the infant. And for that period of time, biologically, we think that it'll offer passive immunity. Furthermore, there's also evidence that antibodies are in breast milk of immunized pregnant, or those women that were immunized, whether during pregnancy or afterward, and those are also passed to the infant. So these are two wonderful ways that mothers can continue to protect their babies by receiving the vaccine and then therefore being able to pass those antibodies on to the infants. We don't have data yet about exact infection rates in infants, but again, biologic plausibility and our historical data, we feel that this is a very reassuring benefit for passive immunity.
Thank you, Dr. Aziz. We're now going to switch gears and talk about how COVID can affect our heart. Dr. Reed Singhani, COVID-19 affected a lot of patients with heart disease, and COVID also caused some new heart problems for the very first time in several patients. How does COVID affect the heart? And can these heart problems persist even after recovery from acute COVID?
So thank you, Dr. Rohatgi, for that question. So heart involvement in COVID-19, it's actually really a spectrum of disease based on what's reported so far. And so at one end, you have asymptomatic patients, no symptoms at all, but they may have abnormal cardiac tests like the troponin level, the Ddimer, the BNP. And sometimes they have ECG abnormalities, echocardiographic or other cardiac imaging abnormalities. And on the other end, you can have patients who have symptoms, who have really, proper cardiac issues, things like heart failure. The heart pump is not working. They may hold on to fluid and sodium. Their arrhythmias have been described, both atrial and ventricular arrhythmias, which really in some cases can be life-threatening. And these can also be affected by certain medications that are given, electrolyte abnormalities. So a lot of things kind of cloud this picture. In addition to that, if COVID involves the lungs, which it often does, if they have the adult respiratory distress syndrome or they develop blood clots in the lungs, we can sometimes see that the right side of the heart, the right ventricle, will fail acutely. And so this is, this can be a big problem. And then I think going to the far end of the spectrum, what we see from the cardiac perspective is cardiogenic shock. And that's the syndrome where the heart pump is really not able to maintain the circulation required for the rest of the organs to be perfused. And to that end, we've actually seen that there has, it's been reported in the literature that there is a higher incidence of cardiac arrests, both in the hospital as well as in the outpatient setting, that has actually been seen at a higher level during the pandemic, as versus to patients, in previous years when they measured these things. So it's really a very big spectrum. One thing that is very important in the context of cardiac involvement in COVID is that we're still truly trying to determine how these mechanisms occur. Because, a lot of people on this call have experience with very severe and very critical illness. And we know that in these settings, we do see abnormal cardiac function. So, cardiac cardiomyopathies, we see troponin elevation. So how much of this is truly related to being part of a critical illness and having this inflammatory response, and how much of it is related to the virus affecting the heart? And those studies are still ongoing. They actually haven't been too conclusive as yet to see that the virus truly affects the heart. And in that, setting, I do want to talk about another thing which is called acute cardiac injury, and that's manifested by an elevated troponin level. That has been very well described in COVID, but that's really an umbrella term that includes many, many causes. So some of these causes are things like what we call a type 2 myocardial infarction or demand ischemia, where there's a mismatch between how much blood the heart muscle needs to get and how much it's able to get due to physiologic stressors like having an acute infection, having, blood pressure issues, things like that. But COVID is also a disease of inflammation, and inflammation of smaller blood vessels can also cause this type of damage. And another thing is something called myocarditis, which has been asked about in the chat quite frequently. Myocarditis is inflammation of the heart muscle. It was very well described early on in the pandemic. And we do see inflammation of the heart muscle both as through a troponin level as well as through an MRI. But we haven't conclusively been able to prove that the virus truly invades the heart muscle. So, a lot of infections and a lot of critical illness does cause inflammation of the heart. So we see that with COVID as well. We also see something called stress cardiomyopathy, where the heart function declines acutely in the setting of physiologic stress. And the cytokine storm or the inflammatory response that has been described can also affect the heart. So it's a very, very big spectrum. What I do want to say from a practical standpoint is, for an individual patient, what's really important is to recognize the symptoms early. If there are symptoms that don't make sense, chest pain, shortness of breath that doesn't seem quite related to the oxygen level, leg swelling that's unexplained, then those are reasons to go to the hospital, because those things really are managed best in a hospital setting. And then one more thing I do want to say is about the troponin level. It's been very, very highly written up in the literature. It's not just a marker of cardiac involvement. It's also been shown to correlate with the severity of illness in COVID, just like the Ddimer, just like the BNP. So we do follow this sometimes, especially for our cardiac patients. Again, these things are all done in the hospital setting. So if patients have concern of cardiac involvement, then honestly, the hospital is the safest place.
Thank you, Dr. Ritsingani. This was an excellent response. I know that you mentioned so many cardiac things that can happen. Are they common or are they more rare?
That's an excellent question. So I will say that the troponin elevations, because I've talked about so many causes, the actual troponin elevation or acute cardiac injury, that we do see, and that has been described to correlate with the severity of illness. What actually causes it? Is it just a response to the severe illness and inflammation, or is it truly cardiac damage? That's the part that we're still studying. And I think over time we will have a better response to that. But we certainly have seen cardiac issues. I think one thing we can say for sure is, do these things persist in the long run? So patients who don't have underlying cardiac disease, when we see cardiac involvement in COVID, what happens in the long term? So early on in the pandemic, there were a couple of studies that suggested that cardiac inflammation, troponin elevation does persist. And, these came from Germany and China and other places. But I do have good news for the audience. We have a study that came out pretty recently. It was an imaging study from the US and the UK, and they actually looked at healthcare workers, and they found that patients who had milder COVID, 3 months out, 6 months out, actually didn't have a lot of cardiac inflammation or cardiac damage. So I think that was one thing that was quite promising. So a lot of this is, the commonality is based on really how severe the illness is, and the recovery is also based on that.
Thank you. We have several more important questions to cover, so we're going to go a little bit over time, if that's okay. Dr. Rogers, you saw several patients in the ICU who had severe heart problems as well. Is there anything that you would want to add from your experience in the ICU?
No, I would agree with Dr. Rijan Shani, sorry, that often the heart and lungs are in danger together. So a lot of our patients were very sick. There are some questions in the Q&A as well about effects on the brain. And we often saw that our sickest patients with bad ARDS, bad lung inflammation, also had bad shock, very low blood pressure, sometimes a very poorly working heart, and also got very confused, needed a tremendous amount of sedation, really unusual. The good news was that many of those patients, if we could get them through their ICU stay, did recover, and the heart could recover as well. So I agree that there's a lot more that it's such a hard virus to understand because there are so many different things that can happen to patients. But the good news is that even very, very sick patients, if they're able to get the care they need in an ICU, can often recover.
Thank you. Dr. Subramanian, are the current variants in India more likely to cause heart problems?
Not that we know that we don't think the variants are causing more in the way of heart problems. It may be more transmissible from person to person. And so more family members are getting infected, and but I don't know that there's any data that it's causing more in the way of heart problems.
Thank you. Dr. Reed Singhani, there was an excellent question from one of the audience that if a patient is already taking clopidogrel or aspirin for their heart conditions that they already had before COVID, and then they get COVID, should they increase the dose of these medications, the aspirin and clopidogrel, or on top of that add enoxaparin or rivaroxaban or apixaban? What should they do?
Right. So, these things are definitely coming up. What I will say is that there are certain medical conditions, including obesity, diabetes, heart conditions, that have been associated. If you have those at baseline, then it has been associated with more severe COVID. And so that's where these questions are really coming from. If I have heart disease, what happens, in the long run if I get COVID? The one thing we do know, we don't have a lot of evidence and a lot of data as to what happens in the long term. We do know in the short term that these patients may be at higher risk for COVID. But I will say that, there's no evidence to support increasing doses of medications that patients are supposed to be on. What is extremely important is to make sure you keep taking them as much as is feasible. Of course, I'm saying if there's no bleeding issues or nothing else, you continue your medications as prescribed. But I do want to actually take this opportunity to say that patients with underlying cardiac disease, independent of COVID and in the context of COVID, so these are two things together, we have noticed, and there has been research published on this, that the incidence of heart attacks and hospital admissions for heart attacks dropped quite dramatically in the beginning of the pandemic. And that really didn't make sense to us. Where did the heart attacks go? Because there's a certain number we see every year. And anecdotally in the hospital and in our clinics, what we have seen is that patients, now that the pandemic is moving into a different phase in the US, we're seeing more patients come in with heart attacks. We're seeing sicker patients come into the ICU with heart attacks. And so a lot of it is just, hesitancy to get care. And I think anyone with underlying cardiac disease, my advice would be continue taking your medications as much as is feasible, but also keep an eye out for symptoms that would make you go to the hospital. So chest pain, radiation to the jaw, radiation to the arm, anything associated with sweating, nausea, feeling like you're going to faint. These can all be cardiac symptoms, and really there's no safer place in the hospital for someone who's experiencing those symptoms. Whether you have COVID or you don't have COVID, the safest place is the hospital. So I really would like to stress on that. Don't make changes to the medications yourself, but try to get care. I know it's very difficult in India sometimes, but the one place, cardiac emergencies, if we get care soon enough, really lives can be saved. So this is just my appeal to everybody.
Thank you. And Dr. Reed Singhani, very quickly, several of the patients who've recovered from COVID, they mentioned that their blood pressure has been fluctuating off and on, and they've been still having some uneasiness in their chest or chest discomfort weeks and months after recovery from COVID. Do you have any comments on that?
I do actually, because we do have some research on this now. So anecdotally, I will say at the beginning of the pandemic, we were seeing this in our clinics anyway. Patients who were recovering had all these blood pressure and heart rate fluctuations. This has been studied a little bit more, and it kind of falls into the umbrella of what we now call post-acute COVID syndrome, or long COVID is the colloquial term. And COVID, as people know, can affect the blood vessels. It causes inflammation, what we call an endotheliitis. That's an inflammation of the blood vessel lining. And when that happens, there are certain pressure sensors in the arteries that can be affected. That's one part. The second part is that there's something called an autonomic nervous system, which all the physicians will be familiar with. It's the sympathetic and parasympathetic nervous system, which controls involuntary responses, including blood pressure and heart rate. And this also can have some effect in COVID because it's really at the center of an inflammatory response. So when you put all these things together, as well as putting in something like people who are on prolonged bed rest due to an illness, dehydration, certain other effects from the virus that are being studied, when you take all this together, we certainly can see fluctuations of blood pressure and heart rate. It's been quite well described. And what that means is certainly with postural changes, you may see patients' heart rates jumping up, blood pressure dropping, all sorts of different changes. And this is, not only is this being studied, there are clinics being set up to kind of monitor this closely. My advice for patients who are going through this is usually when we see these things in the context of COVID, several weeks or several months after COVID, as long as there are no high risk symptoms, and we talked about some of those, but as long as the baseline parameters are stable, there are no high risk symptoms, then the way to start treating it is very conservative. So improve hydration, try to make those postural changes very slowly. So don't jump out of bed in the morning, take a few minutes and change your posture. If you feel dizzy or lightheaded, the thing to do is lie down and lift up your legs from the waist. That improves central blood pressure. So all these little things can actually make a very big difference. But a word of caution to everybody, certain things like elevated heart rates, low blood pressures, they may not be related to some of these post-COVID symptoms. They may be related to dangerous things like infections, blood clots, heart failure. So if you have other symptoms besides just the post-COVID recovery, then that's also a reason to seek medical care.
Thank you. Dr. Schroeder, did you notice any heart problems in children after COVID, either in the acute illness or in the long term?
For acute illness, we unless, as others have said, patients are really sick. Sometimes there can be some heart and lung interactions. But the one thing that's been described that Dr. Matthew alluded to a little bit is cardiac involvement with MISC. But actually, we do have some good news on that. Just yesterday, a paper was published in Lancet that looked at long-term heart outcomes in kids with MISC. And I think all but one of something like 50 had completely normal echocardiograms 6 months later. So that was really good news. Some kids do still get really sick and develop cardiogenic shock during the acute illness with MISC, and we have to support them through that. But it was nice to see that it seems like the long-term ramifications are pretty minimal.
Oh, that's excellent news. Dr. Aziz, what about any heart problems in pregnant women just from COVID?
That's a great question, and thank you. Similarly, pregnant women with underlying cardiac disease are at increased risk for adverse sequelae. There have been a limited publication, a case report of 7 women who had severe illness, and 2 of the women who were pregnant of the 7 total had a myocarditis. However, that hasn't been replicated, and we haven't seen that trend published or reported as much. So it may be a possibility, but we just don't have enough data. And fortunately, pregnant women, again, are quite young and recover well. So hopefully it won't be too many cases, but it may be a possibility and has been reported in few case reports.
Thank you. We're now going to switch gears again and talk about how can COVID affect our lungs and other parts of the body in the long term. So Dr. Rogers, I'm going to go to you first. This has been a big worry for many. How long can this virus stay inside our bodies and cause symptoms? What tests can we do to know if it is really gone from our body, or will a patient continue to have symptoms for months after?
Yeah, thank you for that, Dr. Rohatgi, and again for inviting us to be in this wonderful symposium together and to get to speak to so many physicians and family members. I think you're asking 2 big questions. One is about shortness of breath and symptoms, and the other is about, is it the virus still in me and am I still infectious? So I can say that for people with a healthy immune system in our hospital, after between 10 and 20 days, if you have a healthy immune system, you are no longer considered infectious, and we don't do routine testing. If you are very immunocompromised, there have been questions about transplant patients, et cetera, in the chat. In those patients, sometimes we'll do extra testing to see, is the virus still around? But what we do see is that even after the virus is gone, patients do have a lot of symptoms still in the hospital. They're often there. We had patients that were in our hospital for months, and also patients that I've seen in lung clinic, and I'm sure others on the call as well have seen months later, that a subset of patients will have really long symptoms. And in terms of the lungs, I'll say that one of the most common and bothersome complaints is shortness of breath. That's something that people will often say after COVID. And I'll just say that there are a lot of different things that can cause shortness of breath. So lung fibrosis is a question that people have, and that is one that's very dangerous. But a lot of other things, like just being very sick and being in the hospital, taking steroids, being in your bed, can really make people lose a lot of their muscle tone and have a hard time walking. Sometimes people have depression. Sometimes people have anemia. There are a lot of things that make people short of breath. So this is really something that does need seeing a doctor. And I would absolutely echo what others have said, to actually get medical care is important. One really important branch point that I use in my lung clinic is when people are walking, is their oxygen falling? That worries me about that patient's heart and lungs. If instead they're really short of breath, but their oxygen is quite good, that makes me think more toward maybe it's partly just deconditioning. They've lost weight, they didn't eat, there are all sorts of other problems. But I'm a little bit less urgently worried about their lungs if the oxygen is staying okay with walking. That for me is a major branch point when I'm seeing a patient.
Thank you, Dr. Rogers. Dr. Subramanian, would you like to add to this?
I agree with everything Dr. Rogers said. I would just say, I guess we could get into long COVID. I mean, that's an umbrella term that really seems to cover many different things. And, as Dr. Rogers said, that has to be distinguished from the post-ICU syndrome and sort of recovery from being on a ventilator or being sick for so long. So those are things that are expected to some degree. But there are symptoms that are, even in mild patients, people who weren't in the hospital, that people are experiencing long term. And that's what long COVID entails. It's not the actual virus. It's not thought to be actual virus causing the illness. It's more of a triggered, maybe an inflammatory response. We're still learning about it and studying this, whether there's neuroinflammation. So people often have fatigue and headache, and they may have different types of symptoms. They may have neurologic symptoms where they feel dizzy, and they may have symptoms where their heart rate jumps up, like the postural orthostatic tachycardia syndrome. They may have GI symptoms with diarrhea or changes to their microbiome causing various problems there, and they can have long-term pulmonary symptoms. But we don't know how much of it is a direct effect of the inpatient stay, but it's even being seen in patients with mild illness, people who have shortness of breath, chest pains, and trouble with exercise tolerance, and they have post-exertional malaise and other symptoms. So there seems to be different things going on. Some of it may be sort of an inflammatory process that's triggered initially by the virus, and people still may have symptoms even 6 months to a year later, but it's a very small number of people that we're seeing like that.
Thank you, Dr. Subramanian. Dr. Rogers, could you tell us a little bit about lung fibrosis, and does everyone who gets COVID get lung fibrosis?
Yeah, so lung fibrosis is what we would call a scarring of the lungs. So instead of having a very thin layer between the blood flowing to your lungs to get oxygen and the lung tissue, instead it gets much thicker. And so it's hard for oxygen to pass, and you'll have low levels of oxygen, especially as you walk. There are a lot of different things that cause lung fibrosis, and we do see it in a subset of patients with COVID. But I would say it's a small minority of patients. There are patients who have a lot of lung inflammation, but it's not quite scarred, who need additional steroids, something called cryptogenic organizing pneumonia. And so I do think if you're having low oxygen, weeks later after your original COVID, it is worth seeing a lung doctor to look into those things. Lung fibrosis can be a difficult problem. Sometimes we are seeing patients that continue to have their lung keep scarring worse and worse, and that even need lung transplantation. But thankfully, as Dr. Subramanian was saying, that's actually fairly rare. And much more commonly, we see patients that feel really terrible, but their CAT scan doesn't look so bad. And so really, these are things that need input from someone. Another important point that she made was that a lot of people who've been critically ill will be very short of breath for a long time. And so there again, what I recommend is if your oxygen is okay and you can walk, if you're at home, if your oxygen level is safe, keep walking. Don't, just stay in bed. Sometimes people are so protective that people don't walk at all. But if the oxygen level is over 90 and you can keep moving, not losing the ability to walk early, during those weeks where you're sick, is good to avoid. We see that in our intensive care as well, and try as soon as possible, as soon as it's safe with extra oxygen, to get people out of bed and have them walking so they don't lose so much of their function, because the long-term effects of these illnesses are quite bad, even without having lung fibrosis.
So Dr. Rogers, I know this question was asked of us many times, that what is the treatment for lung fibrosis? Are there any medications besides steroids? And we talked a little bit about steroids last time as well. Is there any magic treatment to treat or prevent lung fibrosis?
There is no magic treatment to prevent lung fibrosis, and there are studies happening to see whether some of the medications that are used in other types of lung fibrosis for IPF might work. Those are being studied now, but we don't know that yet. And so I can say that for us, we do have patients, even very young patients, who are on the ventilator machine, and it's been more than a month and we can't get them off. We don't start using other therapies. People are asking about ivermectin, other options, statins. We don't use those kind of things because we don't know that they can help. So unfortunately, this is again something that needs to be thought about in conjunction with a lung doctor who carefully decides, is more steroids good for you? I will say in the chat that there are a lot of questions about Mucor, and there's the very serious concern that people are getting exposed to tremendous amounts of steroids, far more than what was recommended in the recovery trial, that may be adding to that risk. And so these are not things that you should feel like you as a family member need to consider at home, but really with a physician who can help who has access to CAT scans, et cetera, to help guide you to make sure that therapies aren't doing more harm than good.
Thank you, Dr. Rogers. And Dr. Subramanian, I'm going to take a quick diversion because there have been multiple questions about mucormycosis, something that we talked about last time as well. But Dr. Rogers mentioned steroids in the acute illness, and then weeks later, if the patient's not recovering, to carefully consider with another physician that does the patient need more steroids or not. How can you help our audience just tease out this fear of black fungus and the steroids?
Yeah, mucormycosis, there have been many more cases than what is usually seen in India. Numbers have really gone up. Already, numbers of mucormycosis are higher in India than in other parts of the world, higher than our rates here at baseline. But I think it's a multifactorial process that's going on. First of all, yes, high doses of steroids reduce people's immune system, and they are more likely to get these types of infections. And high blood sugars, diabetes is already very common in India, and now with the steroids on top of that, people's blood sugars are going out of control, and when they're sick, it's really another reason. When we give antibiotics unnecessarily, the good bacteria in our bodies get killed off, and we're more at risk for getting these sort of opportunistic infections on top of them. And then there's some concern as to whether some of the oxygen concentrators or other things may not be getting cleaned properly, and could that be a risk factor? It certainly could be, it's hard to tell from here. And so all of these together, I think, are maybe playing a role, but the things we can really make an impact in are reducing the steroids, only using them when absolutely necessary, when people are requiring oxygen and they have lower tract illness in their lungs, and when it's really absolutely necessary with consultation with a doctor. And the things to watch for are sinusitis, so black discharge from the nose or bloody discharge from the nose, or if you're coughing more than usual and even bringing up dark phlegm, bloody phlegm, these are concerning signs, and really people need imaging, and they often need biopsies to really prove what's going on. You don't usually just treat it with antifungals. It actually often requires some sort of surgical debridement as well. So getting ENT surgery involved soon if this is a problem, and then giving antifungal treatment. But really the antifungal treatment is sort of the last step. It's an adjunctive step. There's many things that come before that, and keeping people's blood sugar levels low and keeping track of that is very, very important.
Thank you, Dr. Subramanian. Dr. Rogers, I'm going to ask you one more question about lung fibrosis. When the patients come to your clinic, you mentioned that you want to see how their oxygen is when they walk. Is there any other blood test or imaging or anything else that you do for them that you would recommend?
Yeah, the big things that help me when I'm thinking again about patients with shortness of breath, and I'll say that in our lung clinic at Stanford, most of the patients that we are seeing after COVID with shortness of breath do not have lung disease. That's been our experience. And so the oxygen is a big branch point for me. I think a lot about the heart and ask questions about that as well. In terms of the lung themselves, you can get pulmonary function testing, which shows you how is the lung functioning. Is it, if it's very reduced, that would worry me. If it's normal, and I listen to their lungs and I don't hear any abnormalities and have normal lung function and they don't have a low oxygen, that might be where I stop. If they're telling me some worrisome signs or any of what I just described is abnormal, I do think a CAT scan could be helpful in that setting. And it can really tell me, is this lung scarring, that is less likely to get better, or does it have certain patterns that look to me like something that might improve with more steroids? But just as Dr. Subramanian said, it is not a free lunch with steroids, and I do not recommend that for the vast majority of patients that have long-term symptoms.
Thank you, Dr. Rogers. Dr. Subramanian, I'm going to give you the last question here. Could you tell us a little bit about long COVID? You've studied this extensively. What were the most common symptoms that lingered on for weeks and months after recovery from the acute illness? And one of the questions from the audience was, does this virus enter our nervous system and stay there?
Yeah, as I said, it's long COVID seems to be an umbrella term, and it's something that by definition lasts more than 4 weeks from your initial illness. So in terms of numbers, we know from large surveys of people, there's a mobile app that was launched in the UK and showed about 1 in 10 patients still had symptoms at 4 weeks, about 1 in 20 patients still had symptoms at 8 weeks, and about 1 in 50 patients still had symptoms at 12 weeks. So people are having some improvement over time, but it's still significant numbers when you think of millions of people infected. What are the most common symptoms? Fatigue and headache are the most common symptoms. But as I said, there are different categories of symptoms that can accompany this. You can have neurologic symptoms with cognitive dysfunction, that's brain fog, people getting confused, their memory, their attention can be low. And as I said, they can have headaches and other neurologic issues can come up. Then you can have pulmonary and cardiac long-term effects. Mostly these are associated with more severe disease. So if you've been in the hospital, then you're more likely to have those, but you can have some of these symptoms even long-term. And some of the autonomic dysfunction that Dr. Reej Singhani talked about can also happen, where you stand and then suddenly your heart rate can go up very, very high. It's called POTS, and it's something we're seeing. And GI side effects we're also seeing long-term. So there are different groups of symptoms that are going together. We think that it's not the virus causing the problem long-term. We think it's a triggered inflammatory response, whether it's a neuroinflammatory response or some other response long-term. Though we are seeing some improvement even with vaccine. Up to 40% of patients report some improvement in their symptoms after getting vaccine. So there may be some effect on the inflammatory response, or if there are small viral particles somewhere in the body, then maybe they are getting eradicated with boosting the inflammatory response. But we are studying this, and we're looking into further treatments that it may not be one size fits all for everybody. It may really be depending on what type of symptoms you're experiencing long-term that we can really target your treatment, but we're still learning.
Thank you, Dr. Subramanian. I know we are over time, but these were very important questions that our audience asked, and they took out the time from their very busy lives. So we really wanted to make sure that we answer as many questions as we could. I want to thank everyone who was able to join us today for this webinar. Over the next few days, we will post a recording of this webinar on the Stanford Global Health website, and where we have posted several other material as well that may be helpful to you. Thanks again to our fantastic panel of expert doctors today for sharing their expertise and knowledge and experiences for a great discussion, really. And I hope this will help many people. Take care, everyone, and thank you.